I will now invite Dr. Vardhaman Kankaria. He'll be talking on refractive surgery in keratoconus.
Yes.
He has got a lot of work on cross-linking and keratoconus.
Thank you, sir. Thank you, sir. And first of all, I would like to thank Dr. Bharti, sir, for inviting me and including me to his very popular course. This is an end-to-end refractive surgery course where we are actually also discussing about if it is possible to also give a refractive procedure in patients who have also keratoconus. So this is what I'm exactly going to speak to you about. This is collagen cross-linking plus procedures for keratoconic eyes in a case-based approach. I don't have any financial interest. Friends, we all know that collagen cross-linking has been successful in halting keratoconus mechanically, decreasing cornea's deformability, and halting keratoconus progression. This is proved beyond doubt. Now there are more than 2,000 published papers only on keratoconus and cross-linkings around the world. And now we already know that how successful is cross-linking for our patients. Let's look at this interesting patient that we treated back in 2007, Swati, who had come to us with progressive keratoconus with a relatively low uncorrected visual acuity of 20 by 100 and low best corrected visual acuity of 20 by 60, having a relatively thicker cornea, still having progressive keratoconus, and was contact lens intolerant. That time Swati of course underwent a resident protocol collagen cross-linking, and that is where we saw this is the pre-operative topography, this is the post-operative, and this is the difference map. You will actually realize that this topographic rehabilitation is or stabilization is actually pretty good, and there is in fact a slight improvement in topography in itself. The patient, though as doctors we were extremely happy, but Swati was not happy at all, and that was because she was still having low best corrected visual acuity and she was still contact lens intolerant. So then we realized that many of these post-CXL patients do not achieve good functional vision, especially because they cannot tolerate contact lenses, many of them, and most importantly that is because of our remnant component of irregular astigmatism, which is the hallmark of keratoconus. So ideal treatment of keratic ectasia should not be only stabilization of disorder but also visual rehabilitation, and that is the whole concept of this new entity called as CXL+. CXL+ is a combination of collagen cross-linkage along with adjuvant technologies which can be called as refractive technologies in the form of topography guided PRK or PTK, in the form of ICRS, including the cares of current generation and the phakic lenses as well. The CXL Plus has been nomenclated by my mentor George Kimionis in Greece, and I'm going to showcase how this works in case-based manner. So let's look at this 26-year-old patient who had a moderate myopic astigmatism and had a best corrected visual acuity of 6 by 12, had keratoconus which was progressing, had a thickness of 463 microns. So we had already seen that when you're doing collagen cross-linkage, you are not actually addressing the component of irregular astigmatism. And so that we could actually address the irregular astigmatism, both George Kimionis from our group and John Konolopoulos from the other group, we published in the same issue of 2009 in JRS how you can combine a topographic guided treatment along with collagen cross-linkage so that simultaneously you can give patient not only stabilization but also improvement in their functional vision, especially if they are not contact lens tolerant. So the objective here is to regularize anterior refractive surface with topo-guided PRK to improve functional vision. It's not a refractive treatment per se, so you should restrict your ablation to less than 50 microns, and only a partial PRK should be performed. So with the same approach, which is now known as the Athens protocol, in the same patient we improved the patient's vision from 6 by 12 to 6 by 6 vision, and this is the 2-year follow-up demonstrating an excellent regularization of topography in the same. So then we went on to do a very large long-term study, which was a comparison between the Athens protocol in one eye and the Dresden protocol, which is the CXL alone, in the other eye, which we published back in 2016 in very prestigious ophthalmology journal, where we have showcased that the Athens protocol not only stabilizes your keratoconus but also improves your functional vision, and there were a large number of eyes which actually did much better with Athens protocol than just Dresden. But what about this case? This is a 24-year-old patient who had now a corneal thickness of 420 micron. Definitely you do not have enough tissue to do a topo-guided PRK. If that is the case, the million-dollar question is, this moderate cones with thin corneas, inadequate corneal thickness for Reference protocol, so is there a way in which we can still give them topographic improvement? So we all know that mechanical removal of a corneal epithelium is an essential component of standard CXL, and there are a variety of methods which come into play of these epithelial removal technologies. You can do it with manual, with alcohol, or with excimer laser PTK. But now the question was, can the method of the epithelial removal itself help us in improving visual outcomes of our collagen cross-linking patients? So we know from this study of Reinstein, where he has done a very high frequency ultrasound to showcase that there is a epithelial donut pattern in keratoconus. That means that the corneal epithelium is very, very thin at the apex of the cone, and annular fashion it goes on becoming thicker. So as your keratoconus is going to become progressive and it goes in more severe stages, the epithelium is going to become progressively thinner in the apex of the cone. Let's look at this with the help of a small animation. So this is a very high frequency ultrasound of one of our patients. You can see if this is depicted in this animation, and if you are actually using this differential epithelial thickness as the masking agent and use a 50 micron transepithelial PTK, which is going to top off not only the epithelium but also a bit of apex stroma, and that is going to cause a bit of flattening at the apex of the topography, thus giving rise a topography guided simulation of our outcomes and give rise to possibly a much better functional vision to the patients. So this was the hypothesis that we started with. To prove this hypothesis, first we published a single case. This was in European Journal of Ophthalmology, and we showcased that you can see that if you look at the preoperative topography and the ablation with on the Bowman, it is very, very let's say similar. And this is the post-operative topography demonstrating that there was a significant improvement in topography of these patients post PTK and CXL combination. That is what now is called as the Cretan protocol. Then we went on to do a large-scale study again to compare the Cretan protocol in one eye and the Dresden protocol in the other. So in this cases, we had 31 eyes which were randomized between the two, and we demonstrated that the PTK with CXL demonstrated a statistically significant better outcomes when it comes to uncorrected, best corrected, as well as corneal astigmatism. So in all ways, the Cretan protocol superseded the current generation Dresden protocol. We have published now 3 papers in long run, and this is our latest paper which showcases the 4-year outcomes of Cretan. Now we will go to the third case scenario where you can actually see that this patient has a thinner cornea, extremely high astigmatism of 16 diopters or so, of course unsuitable for PRK CXL or topo-guided PRK CXL. Only PTK CXL is not going to improve his vision in any way. So in this case, then the BCVA is about 20/60 part or 20/70. What is the best modality that you have? In these patients who have very, very high regular astigmatism, it is better that you visually rehabilitate this patient with the help of any form of ICRS. You can use Intax, you can use the Kera rings or the current generation of Cares. I'm not going into the details of all of them because the restricted time, but you can do it in the manner, either you can do it in the 2-step manner where you have done a Intax first and then after 3 to 6 months do a cross-linking, or you can do it simultaneously again. And now large variety of centers have now moving to the simultaneous Intax with cross-linking in itself. So when we use this approach for this patient where the Intax SK was used, you can see the astigmatism dropped from 16 to almost only 3 or 4 diopters, and the vision improved from 20/60 to 20/70 now, 20/60 best corrected to 20/70 uncorrected. So this patient actually improved vastly and actually got a fantastic refractive outcomes. Now there are going to be a lot of patients that you pick up in mild to moderate stage who still have an excellent best corrected visual acuity by spectacles 6/12 and beyond, but these patients many times have extremely high myopia along with astigmatism, and these patients of course again cannot be helped with either PRK CXL or only PTK CXL. So in these patients, one of the best modality is to combine doing a cross-linking first to stabilize keratoconus for almost 6 months and make sure that your keratoconus is very stable, refraction is very stable, you have a reasonably good functional vision with the spectacles. Then you can choose to do a toric ICL for these patients, and these patients do extremely well. So again, looking at this patient from almost counting finger uncorrected visual acuity, the patient has improved to 6/12. And the best corrected visual acuity also improves in many of these patients because of debulking of large defocus and coma aberrations, and that improved to again 6/9 or 20/30. So this is the algorithm that we go for. Always make sure that you are actually using all the modalities that are there with you. But the CXL Plus approach is a new approach. We are experiencing a major change in the ophthalmic practice today, and we are definitely providing further solutions to improve patients' quality of life, quality of vision in the form of CXL Plus, which is probably the only way to go to the future with a method which offers you both a complete combination of stability and improvement in visual acuity itself, and selection of adjuvant refractive procedures have to be done in very individualistic fashion, and the patient characteristics have to be taken into account. So I would like to thank again Dr. Bharti sir for inviting me and including me into his very fantastic symposium. Thank you, sir, again. Thank you.
Thank you, Vardhaman. Thank you. Wonderful talk on
you, sir.
management of coexisting keratoconus along with refractive error. This is very comprehensive. I am sure if you have any questions, please ask. Vardhaman is here to answer your questions.
Yeah, thank you.
So in terms of visual rehabilitation in KC patients, the last case that you showed where phakic IOL was implanted, I just want to understand how does it compare to a spectacle or a contact lens in terms of quality of vision. Quantity is definitely possible to achieve, but there's always a bit of a debate of ICL and KC is why the questions are.
Yeah, I think it's a very good question, and the most important crux of this question is selecting your patients very well. What does that mean is that your patient should have beforehand a excellent functional vision with the spectacles. So basically you're looking at patient who is already having about 20/30 or 6/9 vision, and he has keratoconus which is stabilized. Fortunately, you picked it up in the early stages, and now the patient has any amount of myopia or astigmatism, but you can give him definitely same quantity of vision or better quantity of vision than even spectacles with the ICL, because in ICL many of them actually would gain about a line of vision, especially if they are already having high myopic astigmatism. When it comes to the, let's say, contact lenses, if you're actually talking about just soft contact lenses, then the vision of ICL will be equally or better. But if you're actually looking at the scleral lenses, of course, there is, in my opinion, there is no comparison about the quality of vision that the scleral lenses can give. There is nothing that can match it. Unfortunately, a lot of patients do not want the hassle of using scleral lenses on day-to-day basis. And if the vision is already excellent with the spectacles, that means ICL is going to do extremely well. So let's say that ICL can be possible in about 10% of your keratoconus patients. We are not actually talking about in general about each and every keratoconus patient. So it's very important that you individualistically choose which combination you are going to do for this patient. Yeah, thank you.
How much the cone centration matter in placing this ICL cases in this eyes?
Absolutely, sir. I think another extremely pertinent question, because if the cone is eccentric, we see more irregularity in astigmatism, and these are the patients who have poorer quality of vision. So sometimes it is also possible to perform like a triple procedure in which you have done a kind of Athens protocol along with cross-linking in the first stage, where you have centralized the cone, you have regularized the cone more, you have improved the best corrected vision of this patient. Let's say that the patient has come back from 6/24 to 6/9 part vision now, and the cone is more regularized, more in the center, and that is when we can go ahead and do a ICL in the later times. Yeah.
I would say in these cases you can do a ICRS.
ICRS also.
Along with cross-linking. Let it stabilize for 6 months to a year, and then do an ICL, toric ICL to correct.
Absolutely, sir.
Yeah.
So if the astigmatism is very low, I think then a combination of Athens protocol can be good. But if the astigmatism is high and very eccentric cone, as sir has said, then ICRS of any kind of your choice, and then followed by ICL will be your choice. Yeah. So basically, TREC is an offshoot of Cretan protocol, frankly, because what is TREC is you are actually doing a PTK which is selectively at the cone. In Cretan protocol, you don't have to do it selectively at the cone. Actually, you do it 50 micron everywhere. TREC is a selective PTK which is done at the apex of the cone, which is like doing Cretan protocol at the apex of the cone.
Correct.
So in our opinion and experience, trach performs equally exactly the same in terms of the Cretan protocol versus the trach protocol. If you have a specific exam laser with you which is Schwend, then you can eccentrically take the PTK and do it. The good thing about Cretan protocol is you don't require a specific laser. You can do it with each and every laser right now. So basically what is done in the trach is you are doing a PTK in the center, but you have to remove the epithelium surrounding it. So there they do it mechanically. Okay, either you can do it mechanically, or if you have a, let's say, a diaphragm, you can also do it with the PTK mode. But it is going to work exactly like a Cretan protocol. There is, in fact, the concept is exactly the same. There is no difference, yeah.